The next session I'm very happy to introduce is a bit of a deep dive into what's going on in London, Ontario. As everyone will know, London was the site of the first publicly funded Pluvicto administration back in the fall. And so we thought when we were putting together the program for this conference that it would be a really appropriate session to highlight the important work that's going on in London and showcase some of the leading physicians and researchers that are operating out of London. And also to share some of the lessons that they've learned out of the first 6 months following the public funding of Pluvicto. So taking us through this session, I'm proud to introduce Dr. Meena Sweeha and Dr. Duncan Sutherland from London Health Sciences. Over to you guys.
Thank you very much. So we're fortunate to have several speakers from London, Ontario. We'll be introducing them first, and then the presentation will start. I'll be introducing with Dr. Sweeha. The first one is Dr. Glenn Bauman. He's a professor in the Department of Medical Oncology, Medical Biophysics, and Urology with clinical and academic specialization in genital urinary and central nervous system malignancies. His research focuses on multimodality image-guided radiotherapy and advanced cancer imaging. He brings a substantial translational research expertise to us, particularly in pathology to imaging correlations and in the clinical application of PSMA, PET-CT, and therapeutic strategies.
Okay. So it's my pleasure to introduce the second speaker, Dr. David Lidley. Dr. David Lidley obtained his Doctor of Medicine degree from Memorial University of Newfoundland. He subsequently completed his residency training in nuclear medicine at Western Ontario and followed up by subspecialty fellowships in oncology, PET-CT imaging at McGill University and theranostics at Western. Dr. Lidley possesses extensive experience in the field of theranostics, and he has served as the principal investigator for numerous important clinical trials. His research portfolio includes important clinical trials such as in prostate cancer, such as Vision Trial, Arrow, Splash, and PR21, as well as in neuroendocrine tumor trials such as NETTER2, CCO Osmosis, and Action-1. He currently holds the position of Associate Professor and the Program Director in the Division of Molecular Imaging and Theranostics at Western Ontario. In addition to he is an Associate Scientist at Lawson Health Research Institute, an active member of the Ontario Health Radioligand Therapy OHRLT Working Group, and the Nuclear Medicine Residency Program Director.
And then rounding out the group is Mr. Stephen Nelly. He currently serves as the Director of Medical Imaging and Breast Care Programs at St. Joseph's Healthcare London. He's an experienced leader in medical imaging with a strong background in molecular imaging, theranostics, and radiation safety. His professional interests include radiopharmaceutical therapy, quality assurance, and the integration of imaging systems across healthcare networks. So with that, Dr. Bauman, would you start?
Thanks very much. So I've been charged with providing the historical perspective of the development of the Division of Molecular Imaging and Theranostics, and in doing so, I'm really pinch hitting for Dr. Jonathan Ramza, who's the Chair of Molecular Imaging and Theranostics. But I've collaborated for many years with the group, and Dr. Ramza is attending the graduation of his daughter, so I certainly appreciate why he would want to be there. So London is about halfway between here and Detroit. That's how we describe ourselves, about 200 kilometers southwest. We have two main health systems there. We have London Health Sciences Centre and St. Joseph's Health Care London. We have molecular imaging across all those sites. The majority of the work being done at St. Joe's and at the Victoria campus, where the Cancer Centre is located, where I work. And we're all affiliated with Western University and the Schulich School of Medicine. We like to reflect on our sort of rich medical history and contributions in a number of areas, going back to the first discovery of insulin with Sir Frederick Banting. We also gave the world's first cobalt treatment in 1951, and Dr. James Collop helped develop the vinca alkaloids. So we've had a number of medical milestones over the past, and in the history of theranostics, we can go back into the 70s and 80s with the development of nuclear medicine at Victoria Hospital, which was at South Street campus, which has now been decommissioned. But we had two main physicians there, Dr. Fred Hagee and Dr. Albert Dreger. And really, theranostics at that time really was focused on thyroid disease. So these were experts in thyroid disease and where it got its start in London, as in many places. But even then, we could see the beginnings of other aspects of theranostics. And this was a paper from Dr. Dreger looking at the use of radioactive phosphorus P32 for palliation of bone pain. So even back in 1980 in radiology, a publication on a theranostic or a therapy use of a radiopharmaceutical. In the 90s, which is kind of where I came on the scene, I've had my 30-year pin from LHSC, so I sort of was witness to this expansion and have had the chance to work with a lot of the folks who were in the beginnings here with Dr. Robert Reed, who is a nuclear medicine doc, working very closely with Dr. Walter Kocha, medical oncologist, and Dr. Arthur Porter, radiation oncologist, to develop programs in treating neuroendocrine carcinoma and also expanding our programs in palliation of bone metastasis, primarily in breast and prostate cancer, but now using agents like samarium and strontium. And this is a very interesting paper that came out during my residency, but it's a pan-Canadian, sort of our Canadian theme, but the pan-Canadian trial of looking at strontium versus placebo added to local field radiation for palliation of bone pain and prostate cancer. So this is like the trial for radiotheranostics. So this is like the OMPC trial where they're using lutetium on top of SBRT for prostate cancer, but this goes back to using local field radiation for palliation of bone pain, and then would strontium on top of that delay or prevent new bone complications. So even then, we were starting to do pan-Canadian approaches in this field. In the aughts, we saw more of a focus on instrumentation, and so within London, we were fortunate to acquire a lot of equipment that has helped us build our program, including PET-CT, SPECT-CT, installation of a cyclotron and radiochemistry facility, PET-MRI. And then as we entered into the last decade or so, we started to see an expansion of our therapy program, and the whole effort within London started to take off. We have a Y90 program. We've been giving radium-223, neuroendocrine tumor. We were early adopters of PSMA PET scanning, and we've benefited from nuclear medicine and the cancer program, both evolving their clinical trials capacity so we could participate in a lot of the clinical trials, pivotal clinical trials in this area. And then more recently, we've been participating in developing national standards, like Dr. Steve Nelly spearheading that, working on our own strategic plan as to how we're going to move forward. We have our two new faculty here, Dr. Sutherland, Dr. Swiha, who have been our investment in growing the program and making sure they got exposure to radiotheranostics through our collaborators in Australia. And building on those collaborations and attached to last year's Leaders Program, we had our own workshop with our Australian collaborators to look at how do we work better together, how do we disseminate our knowledge. And over the last year or so, the Department of Nuclear Medicine has now evolved into the Department of Molecular Imaging and Theranostics. As Dr. Laidley will describe, we were first out of the gate in terms of administering Pluvicto that was publicly funded, and that got us a bit of PR. We are a growing team. We kept adding pictures to this as we iterated, and I'm sure we missed some folks. But we look forward to a bright future, and I'm going to pass it over to Dr. Laidley now.
Good morning. I have thank you for inviting me today. I have the pleasure to talk to you guys today about our first 6 months experience with the delivery of Pluvicto. Of many of you people who know me and know our program, we certainly have had our challenges in London. I think we've had more successes than issues, but so we'll just go through some of the story of this program, and I think a lot of the themes that I'm going to bring up today are going to be very similar to the ones that we've already heard. So that drop does not mean there's anything bad here. So again, Glenn's kind of pointed out that London's had a very strong history in radiopharmaceutical treatment and imaging. As mentioned, we had a very strong thyroid program. I think we have one of the few programs in Canada which nuclear medicine will treat high-risk and intermediate-risk patients and follow those patients longitudinally. So we have one of the few longitudinal thyroid cancer programs in Canada run through nuclear medicine. As mentioned, we have a fairly long history with treatment of palliative bone disease, and I think, as I'll point out today, I think the neuroendocrine program in PRT is kind of what I call like a gateway radiopharmaceutical drug for how to run a program, because it's, for many reasons that I'll get into later, it is kind of set up naturally to be a way to deliver treatment in a manner that is relatively palatable and manageable. So in terms of neuroendocrine therapy program, I mean, we've been doing I-131 MIBG and high-dose indium octreotide, and we've been doing those therapies for almost 25 years. We don't do them anymore, obviously. This has been supplanted by Lutathera. We also had, I called it the world's largest third world indium octreotide program, which we ran for many years. It was a great imaging agent when we didn't have gallium, but we've supplanted indium octreotide imaging with gallium dotatate. And of course, lutetium 177 dotatate. Of course, we've been doing that since around 2010. We used to make our own product in-house, and that continued until we joined the osmosis trial, and then subsequently the funded program. So as I mentioned, PRT, in my opinion, is kind of the gateway drug. Thyroid program, slightly different. So I think PRT is kind of the quintessential program to kind of get programs at least acquainted with the idea of a radiopharmaceutical delivery, patient follow-up, patient management. We have a diagnostic pairing, indium octreotide, moved to gallium dotatate, but again, if you look at the post-therapy imaging, again, this, obviously you're well aware, well acquainted with the idea of theranostics. Later on, there's many people in this room who were instrumental in moving the Pan-Ontario trial forward, and this gave centers across Ontario opportunities to have experience in the delivery of lutetium 177 dotatate. It also introduced gallium 68 dotatate, so this was a very important program to kind of disseminate a knowledge and also increase the diagnostic armamentarium that is available. Toronto had gallium first, and then it's been disseminated across multiple sites. And then NETTER-1 obviously has been published. And then, for the most part, in terms of a PRT program, what we see is once we reach sort of a steady state of our program, we don't usually see, at least we haven't seen, a huge change in volumes over time. So for the most part, it's a manageable program for programs. London, because we've been doing the treatment of neuroendocrine disease for so long, going back 25 or more years, we have a very ingrained approach to the management of neuroendocrine tumors, surgeons, interventional radiology, medical oncology, radiation oncology, and now more nursing. This is just our team. So again, this team's been around for a while with few iterations. Again, this is the kind of the model or the gateway drug to delivery of Pluvicto. So again, we did about 150 therapies last year for PRT, about 60 referrals, 40 patients started treatment, and we did about 200 follow-up appointments. So not bad, pretty manageable. Then we move into the Pluvicto state. Of course, Vision trial has been published, which we were one of the few centers in Canada that were participants. And just as a side note, I remember as a little bit more of a junior faculty member contacting Endosite and asking, can we be part of this trial? And emailing their team, and they're like, who are you guys? But they accepted us, and we were able to open that trial. So we're very thankful we did. Because at that time, there really wasn't a great deal of theranostic trials going on at that time. We subsequently participated in Arrow, Splash, PR21. So this gave us a lot of ability to cut our teeth on the delivery of prostate agents. It also, because of our history in neuroendocrine tumors and thyroid cancer, we are quite familiar with the idea of running an oncology-like practice. Of course, Pluvicto was approved in 2022. And as Dr. Bowman pointed out, London, we were very keen on being the first center in Canada to deliver this. And I remember we were looking for patients, and of course the way it opened and the timelines, this was done over Christmas time. So even when I was on vacation, I just told my wife before we went to Niagara-on-the-Lake, I was like, I have to go in to see this patient, and after I'm done, we'll head on to Niagara-on-the-Lake. I'll let her do the packing. So it was great to be involved in that. So just to give you an idea of our current journey in delivery of PSMA therapy in London, we did our first treatment in 2024 in December, and then we had no treatments in January. So it kind of went cold. We're kind of not sure, like, is there anyone going to send a referral? Where are these patients? We kind of expected there to be quite a few patients. Then we had 3 treatments in February, of which one of those was the second treatment of our first patient. And then we had 11 therapies. So it's starting to show some signs of traction. And now we're seeing this sort of upswing as the information around this treatment has become available, as centers are operational, we're starting to see more and more referrals. So I call this like the Pluvicto tsunami. I've used this slide in other presentations I've done. This is not like our PRT program. We are seeing referral numbers that go beyond what we have seen for sure with neuroendocrine. So this is just our treatment calendar. This is actually our real treatment calendar. This is our April, this is our May. So we do Lutatheras on Tuesday. We did radiums on Wednesdays and Pluvictos on Thursdays. And now as we moved into June, we've added Pluvicto treatments to Wednesdays because we can't keep up with the referral volumes. We've actually cannibalized our cardiac program on Thursdays to manage the delivery of Pluvictos on Wednesdays. So as you can see, we're starting to move from 1 patient a week to 2 patients on Thursdays to 4 patients on Thursdays to now 2 patients on Wednesdays. And for sure, we could use a little bit more room to add and expand that program. So this is a little bit of a catchment area of our referral base. It pretty well covers most of Ontario. We haven't had too many referrals from Northern Ontario, but we pretty well have had referrals from all across Ontario. And so to date, again, we're only at 6 months, really. So neuroendocrine program, we had 60 referrals. So far this year, we've had 70 new patient consults for Pluvicto. We've started to treat 28 patients. We've done about 68 doses so far, and we have 10 patients booked to get treatment later this month. We have 8 patients on hold. This is a different treatment program than neuroendocrine tumors. We do have some patients that will be held, but because of the severity of the disease, the advanced age, and the type of patients that we're seeing, we have to obviously hold treatment when appropriate. So we have about 8 patients on hold, and we have 12 referrals as of when I created these slides that have not yet been seen in referral. So I think the key pieces, and I think this has probably been mentioned already today, you need staffing. Because this is an imaging-driven process, you need PET capacity, you need physicians, and you need treatment space. Our program is kind of most of the treatment and the whole process is under the umbrella of nuclear medicine. We have our radiation colleagues and our medical oncologists who are great team members that help us manage these patients, but for the most part, the referral intake process, imaging, consultation, process happens inside. So my nurse sits outside my office. My bookings clerk for PET is a little bit down the hall. If we need anything done, we kind of just tap people on the shoulders and get things done. So we have a team, Dr. Sutherland, Dr. Sweah, both trained in Australia with some great people down there in Peter Mac and St. Vincent's. I'm not sure who the guy with the mustache is. That's a holdover from when Movember happened, and I said, I'm not shaving my mustache off until we have our first treatment with Pluvicto. I have to say I did hold on to the mustache a little bit longer than December 27th. And Dr. Ramza, who is actually an internal medicine trained nuclear medicine physician, is, I call him our favorite new fellow. He's sort of getting indoctrinated to the theranostics approach and has been instrumental in helping us deal with the capacity issues. We're fortunate enough to have 2 state-of-the-art PET CTs between our 2 hospital systems. And maybe they don't look so fancy, but having actually decent lead line space, We have capacity to do 2 treatments per room. Perhaps with some modifications, we could treat maybe 4. It has its own bathroom. I know it sounds silly when you talk about bathrooms, but for people who do this type of treatment, that is a concern. So we have infrastructure, we have PET technology, we have physicians. This is our sort of our MCC. Not everyone's included here, but you can see me in the middle there with a beard. So in the last year, I've changed my look. I'm a little bit like a man of mystery, I guess. And there's another guy here. So you never know what you're going to get. So yeah, our MCC team has been extremely instrumental in the ability for us to work through the volumes. Dr. Bowman and I helped set up a theranostic tumor board, which we used to do once a month. It was more of a interesting case or a talk about scientific research. And once we started Pluvicto, we realized very quickly, like, we need to see these people get into tumor board fast. Our GU rounds are completely packed, and we thought this would be a great avenue to allow us to facilitate patient flow. So we have seen patients on Tuesdays in clinics, did their PET in the morning, consult in the afternoon, tumor boards on Thursday, and then we book a treatment. So we can get patients through really quickly, and it's been working really well. But as I say, we're a victim of our own success. As we treat more people with 6 cycles, we start to run out of treatment capacity. So this brings me to my final point of the presentation today about our ability to have people help us do this treatment. So this is a slide. That graphic is our nurse, Jeremy Massey. He is our RLT nurse, and it was mentioned this morning that the CHUM has one. We were fortunate enough to have a nurse added to our team about 2 years ago. He was a great help in our neuroendocrine program and is an exceptional help in our PSMA PET program, or our Pluvicto program. This is the graphic he often uses for a nurse. He's not quite versed in ChatGPT. So when he started this role, he had really no expectations of what he was going to do. We kind of needed somebody, and the cancer clinic was willing to fund a position, and he started. And then as we grew in the program and Pluvicto launched, you can see under the Z, what he does is actually very comprehensive. If he takes vacation, I'm not sure what we're going to do. We try to reject when possible, but we need to clone him if we could. But he does a lot of things. He keeps the program on track. He helps with referrals. He does IV access. He helps with PET IV access, patient lifts. Yesterday, one of our Pluvicto patients almost fell from getting weighed, and he caught them as they were walking by. Might throw off his golf game. I think it twinged his back a bit, but it's just, I can't really describe how much that having that role adds to your program. So I think if you don't have a nurse in your program, it's something you really need to look at doing. So just to give you kind of an idea in more detail, patient coordination, just the intake of patients, communicating with patients. As you know, the treatments are being delivered, on demand, in very little notice. We have a couple of weeks to order doses. If patients get hospitalized or have medical issues, that dose is extremely valuable. So you want to make sure you either move that dose to someone else or cancel that drug. He deals with everyone in the department, communication with the doctors, communications with oncologists, communication with the technologists, communications with leadership. Jeremy's not been shy to communicate some issues around not having enough supports, and we've been advocating to continue to add to our program. And he helps our research programs as well. We have a lot of research theranostic programs that we're delivering. He helps discuss treatments with them, as well as setting IVs and blood work and things like that. So in his own words, he says that this role is not just about supporting patient care, it's about helping the entire team function cohesively, ensuring operational success. So I think every treatment program has to be operational and be successful, but because we're dealing with a pharmaceutical that has a half-life and an expiry date, it even becomes more critical to have a well-oiled machine. And this is another quote from Jeremy, who was talking, not a Monday goes by that not one of our patients are admitted to hospital. This is not a reflection of the treatment. This is just a reflection of how sick some of these gentlemen are. And if you can imagine, if you're being admitted to hospital on a weekend or a Friday, and you come in Monday and you're doing treatments on Wednesday or Thursday, most families are not contacting your hospital to tell you that Mr. Smith is not coming in for treatment this week because they're too busy dealing with their loved one. So he'll go in on Monday or Friday and just peruse the charts, make sure they're not admitted to hospital, and if they are, he might reach out and say, how's he doing? And then the next step is to really, dose management. And he does a lot of other things in terms of symptom management, helps coordinate transfusions. Again, big piece is patient and family support and just that collaboration. But one of the key pieces is dose management. We have so many doses coming per week. We have lots of men that need treatment. And just being aware that patients may not come for treatment and being able to move people around, delay treatment 1 week, move them to the next week, is a huge piece in trying to deliver as much treatment as possible. And another quote, patient-centered care, focus on the safe and efficient delivery of RLT to ensure we can provide effective cancer treatment for men with advanced prostate cancer. So again, very focused on having a member like him who's focused on just the RLT program, dose management, symptom management, and even keeping the doctors on track, because we're like a squirrel, and he reminds us to put that patient on for tumor board, order that PET scan, because we forget sometimes. So this is kind of our model. We'd like to see this we don't have any windows because we're a nuke med, so maybe Dr. Paul can install some windows in our next department, but we'd like to see this as an infusion clinic. I mean, we're gonna have difficult patients, but this is a relatively straightforward process. The pre-assessment piece and the post-treatment piece can be complicated. The actual treatment delivery piece, once they're appropriate, is actually reasonable. So we just like to scale this up. We have MRTs, which are exceptional. We need a lot more, and I think that's probably been mentioned here already. We have an RN, and we're soon to be hiring an RPN. So we'd like to be able to scale up to 6, maybe up to 8 or 10 or 12. Sky's the limit. We just need staffing and space, and we have most of the space pieces, but we don't have staffing. So we'll continue to reevaluate. And I think the most important piece I want to leave you guys with is having a great team and the appropriate people. I'm not sure if the guy on the left is me in a few years, but having physicians, which we have quite a few. We have a really great team of new fellowship-trained physicians, nurses, MRTs. I can't stress enough the need to have more nuclear medicine technologists being trained. We're short. I think most programs are short, so this is an area that needs to be looked at significantly. And hiring more. It was mentioned this morning that having nurses in therapy clinics in nuclear medicine or wherever they're being delivered in an RLT clinic are important, because these would not be unusual to have them in a radiation oncology or medical oncology system. It's just not. It's unheard of, but we should follow that same model because they're instrumental in delivery of safe and efficient care. So with that, I'll let Dr. Nelly, Steve Nelly, finish off.
All right, thank you. So I'm going to talk a little bit about the future and just give everybody some insight on some of the things that we're thinking about in London as we move forward. So just to mention, I know it talked about a little bit earlier in the presentation, but London was one of the leaders in developing the Pan-Canadian Quality Assurance Guidelines for radiopharmaceutical therapy. So it started as a local initiative, and it was quickly picked up by our colleagues at Ontario Health and CAPCA. And it very quickly became a national initiative. And so there's quite a few groups that are talking about this. How do we roll it forward? What are we going to do with it next? How do we keep it current? But to give some insight onto what we're thinking, there's a bunch of things on the slide here, but what I wanted to draw your attention to, and things that we think that might be useful in terms of next steps for this document, is the top right talks about launching national benchmarking. So in London, we do a good job of trying to collaborate with our other healthcare partners and getting an understanding of what the landscape is like, but a true assessment and benchmarking exercise from across the country, utilizing the PCQRT guidelines, because they do give you the ability to score in some key main categories, such as facilities and infrastructure, policies and procedure, personnel, to give us an understanding of what exists out there, what sort of trends are there. We'd probably expect to see that the big academic centers are set up in different ways than some of the community centers, which likely in the future will be involved in these therapies. The other thing that we think that there could be some focus on is defining the core requirements versus best practices or aspirational guidelines. So we'd like the document to be something that you pick up in your hands, and if you're a new site, as an example, you'd be able to identify what foundational elements need to be there for you to have a quality program. So just switching gears into talking about the future, and so I was watching, I'm sure most of you know what movie this is, Finding Nemo, with my kids, and I don't know if it's sad to say that my mind saw this scene and I thought about theranostics, but I did. And so in this scene, I'll just recap it for anyone who hasn't watched it recently. So the fish are being captured by the fishing net. They're being pulled up towards the surface, and they're all panicking and swimming in different directions. And so Nemo has the bright idea of, if we can all start swimming in the same direction, then potentially we could overcome the challenge of the net. And so he's able to get these fish, I think they might be tuna, I'm not sure it matters, but they all start swimming in the same direction, and they're able to start bringing the net down towards the bottom of the sea floor, and it eventually breaks the rig off the shipping or the fishing boat, and all the fish are able to swim free. And so when I saw the scene, I thought, hey, that's exactly what we're trying to do in London. We're trying to get everybody swimming in the same direction so we can have a big impact. And so these are all the fish in the sea in London, so to speak, that we have. And I think historically we've done a really good job at collaborating and making sure that different groups are talking to one another, but it's not to say that we can't do better. And so in order to start to look at bringing these groups together under a more formal arrangement, we've launched an MIT, or Molecular Imaging Theranostics, citywide governance structure. And the governance structure is led by the steering committee. So it has experts from the various committees and institutions that were on the previous slide to help guide the direction of the program. Underneath that steering committee sit clinical operations, quality, research and development, and education and training. And so those subcommittees report up to the steering committee, and then that steering committee further reports up to the executive leadership at those various institutions. As we all know, you need to have that executive leadership support to make sure the direction is supported with the future strategic directions of the organization. And so one of the pieces that I want to talk a little bit more about is the education and training, because that's one of the key pillars that we're going to be focusing on as we move this forward. So the MIT, one of the key initiatives that we want the Education and Training Subcommittee to be working on is the London MIT Training Academy. It's a big part of how we see the future, and it's where we believe and where we see that research and innovation are going to meet real clinical practice. So it would have a wide range of professionals and to give them the hands-on experience that's needed to work in this fast-evolving environment. So the vision is simple. We want to create a space where people can train alongside experts, learn from real cases, and be exposed to both leading-edge procedures and research. So it starts by mapping out our innovation pipeline. It's something that I've heard in some of the earlier talks this morning. So it's about understanding how everything fits together. So where do things plug in? Where are the gaps? And how do we design the training with things that we already have in place, and what do we need to have in the future? So one of the strengths that London has had is the link between research and patient care. I think we've done a great job, and if you see this pyramid here, the probe development, the preclinical testing is all very robust, and there's a lot of success in those areas. And then in the real world effectiveness, clinical integration, there's also a lot of success on that end. But we do know and we recognize that there's a gap that we need to address, and that's in the transition zone. And that's going to be a key focus as we build the training academy to help bridge that gap. And just a note, it's in small writing at the bottom of the pyramid. A tool that's coming to London at the Loss and Imaging Research Group is a tri-modality nanoscan imager that's going to help with that translational work. And so the innovation pipeline is not the only pipeline that we need to focus on. It's also the talent pipeline. So when we talk about that, we need to put a focus on identifying the people that we need today and also the people that we're going to need for tomorrow. So it's all the people that are on that slide. It's technologists, nurses, scientists, all of these people that are important at every stage along the journey. We know that success isn't about working in silos. So we know as we're developing this program and this training academy, it's about knowing how to work across disciplines. One of the last remaining building blocks that we're adding to our training academy and we're putting focus into, and it's a big part of is having right infrastructure. So it's not just about buildings and scanners, it's about giving learners real access and the tools and spaces where clinical care and research happen together. So that includes everything from the imaging equipment, PET-CT, SPECT-CT, PET-MRI, we're looking at extended field of view PET, to the production facilities that we have at Lawson and Western University, clinical spaces with the PET injection rooms, therapy suites, and then all the way down to our software solutions that we need to make sure that we invest in to keep up with the integration of AI and the tools that are needed for dosimetry in the future. So the infrastructure is going to give us that strong foundation to support the innovation and the talent pipelines that I mentioned earlier. But it's also an area that we continue to innovate in, making sure that our physical and digital environments keep pace with where the field is going. So I know that the writing is small and that's not the intention, is to read all of the detail on the slide, but what it is meant to do is to show that we're mapping all of this out in London to show how our pipeline is sitting and all the different building blocks underneath. And so if I walk through this document, we're identifying and recruiting highly qualified personnel to make sure we have the right teams in place. We're continuing to develop and upgrade our infrastructure to support both care and research. And we're building key partnerships with academic, clinical, and industry leaders to expand what we can do together. Now, this isn't a complete list, especially I want to draw attention to the partnership side. That's the reason why we come to these events, is to expand on those partnerships, because we can do more together than we can do individually. And the last thing that I'll talk about is just a mention to the field as it continues to evolve. The training academy will have to evolve with it. We're not limiting ourselves to just thinking about the therapies of today. We're going to be building this program for future indications, production methods, and technology. So the structure needs to be flexible so we can offer everything from short-term learning modules to long-term fellowships and academic partnerships. And we're confident that the MIT Training Academy in London will become a national resource for theranostics education, grounded in real-world experience and driven by innovation. Thank you.
Do we have any questions? So I do have one. We've had 3 talks about the history of the program, current challenges, and then where the program is going. I want to know perspectives on some of the challenges that you think are upcoming or that we have very successfully navigated. We'll let Dr. Laidley start, and then we can.
Is it on? Hello? Hello? I mean, it's kind of hard to foresee the future. I mean, the current challenges, I think, are, meeting, because theranostics is driven by PET imaging, we need to have a robust PET infrastructure across Ontario, particularly. I mean, Quebec has a great infrastructure. Other provinces, maybe a little bit less. So that's one piece. Physicians, whether it's nuclear medicine, radiation oncology, et cetera, having people extensively trained in theranostics, having a good comprehension of when and when not to use it will be key. So that starts even just in the residency level and fellowship training level. And even just looking to the future as we add Lutathera, Pluvicto, maybe Pluvicto in an earlier stage, or maybe Lutathera in an earlier stage, the volume of patient increases exponentially. So if we have another agent for breast cancer, or say a new agent like FAPI, how or where are we going to treat these patients? We need space, we need special lead-lined rooms, we need infrastructure to support that. So looking to the future, as mentioned this morning, we build hospitals with the intention of what they're going to need in 10 years. It's really hard to predict where we're going to be in 10 years, but I think we need to overcompensate and really expect that this field is going to continue to expand and plan for the future. So I think those are the infrastructure, personnel, and those are the key areas that I think need to be evaluated.
I think one of the challenges is just making this transition from sort of bespoke programs where you're treating small volumes of patients to programs where you have to have a lot of robustness in dealing with all the vagaries of people not able to attend because of illnesses and things. And I think we have to move beyond the Excel spreadsheet mode of booking patients and more like what we have for larger volume systemic therapy programs and radiation programs where you have robust systems for booking patients and dealing with the scheduling and things like that. A lot of it's not very exciting, but it's what makes the things go smoothly and creates a really robust program.
I think there's a question or comment from Dr. Narendra Ball, London Citywide Chief Chair for Medical Imaging.
Thanks. Can you hear me? Just a comment, really. Great presentation, but I have to say that. There's no department across the country that was not at capacity before Pluvicto came. Right? Everybody's busy. So wherever it's been done, we know the sites across Ontario, obviously London, sort of Ottawa, UHA. Everybody's had to expand capacity, and as David showed, that is almost an exponential increase, right? And so it's always a scramble to say, how do we get this on board? But what we're doing in Ontario, we've got a pan-Ontario working group. Many of the speakers you've seen are on that. And we're putting together the collective expertise to say, okay, as Steve said, what are the core requirements if you're going to do this at your center? Because the absolute intent is to try to get some of these therapies closer to home. So it's not just to keep it in the six hub centers, it's to sort of say, okay, well, if you're a community place which is closer to the patient, how do we help you get to where you need to go? Because there's no question, if we're struggling with Pluvicto and other things come down the pipeline, how's that going to work? Also, it's not conscionable that patients will have to travel hours to get this therapy done if you can do it closer to home, okay? So that's a key thing. The second thing, Stephen, thank you for pointing out the training academy. This is a serious intent from our organizations to say, okay, well, we keep talking about our HHR problem, whether it's in scientists, whether it's in techs, whether it's in nurses, whether it's nuclear medicine physicians. We have this expertise, and we are willing to partner with government, we're willing to partner with training colleges, we're willing to partner with industry to help support training the next generation of. And the one thing I think that's missing from that is we have a really good program where high school students come to medical imaging. They go through our molecular imaging and theranostics department. I have to educate David that we changed the name a year ago, but he's a slow learner. The key thing there is to start the interest at an early age. But as I said yesterday, the key thing for those high school students is, if I go into this area, am I going to have a job? Like, how many jobs are going to be available? Who's training these people? Are we going to be hired in hospitals? And I think we still need to do that math and to say this is a growing field. And yes, it's just like CT, just like MR, just like ultrasound, there's going to be a job for you in the future. So I think this is a call out to everybody in this room to say, we know there's an issue, but we can work together to fix that issue. It's not a hopeless task, and it's just to say that we're willing to do this, and I'm absolutely convinced that other centers, that are academic centers, have the capacity to do the same thing. And happy to chat to anybody in this room at any time to see if how and when you can get involved. And thank you for the presentation.
Thank you. So do we have time for questions? Okay, so I have two short questions, one for Dr. Glenn Bowman and one for Mr. Nelly. So my first question, honestly, from my experience in Australia, okay, one of the keys for success of the Australian model is building a national collaboration in both like academic and the clinical practice. So my question here to Dr. Bowman, okay, do you think how can we build this here in Canada? We have leading centers in theranostics, and we have here today about multiple success stories in Quebec and Vancouver and Saskatchewan, and for sure we have more than one center here in Ontario. How can we build this national collaboration, okay, to take Canada a future step?
Well, I think that I'm not sure that there's a single answer for that, but I guess where I've seen excellent collaboration has been around clinical trials that have engaged investigators across Canada around important questions. So we've seen that through the CCTG PR21 trial, which brought a whole bunch of centers up to speed with capability needed for radiotheranostics treatment, including dosimetry, which I think elevated a lot of centers across the country. It was painful, but it was a motivator. We all saw it was an important question. The other pan-Canadian study, which I think is going to be a practice-changing study, is PATRON, which is a PSMA PET imaging trial looking at targeted treatment based on diagnostic PSMA PET scanning. So I think finding those compelling clinical questions that will allow centers to come on board, rally around clinical trials that encourage development of new approaches, new skill sets, new capabilities, I think that's one way.
Thank you so much. So a question to Mr. Nelly, okay. So now I believe after the publicly funded Pluvicto has came, okay, the field has changed significantly. We have more patients, we have more practices, and we expect in the coming few years we'll have like more in practice like Fabi coming and other radio tracers. One of the most important things about quality, how can we guarantee we have a standardized approach for all these among the different centers? Each center has its own way. How can we get Ontario, okay, or other provinces also to have such a standard practice everywhere? We can have a standard practice for these stuff.
Yeah, it's a great question. I think in Ontario, the radioligand therapy working group is a great start to that approach, is to look at using established guidelines to then say what exactly do you need to make sure that you're practicing at a certain level of quality. I do think that eventually we're going to start to see hub and spoke models come into play, and so you're going to have community centers that may have the capacity to deliver these therapies partner with a bigger center. And so it takes that collaboration of the big centers working together, making sure we're aligning ourselves with how we practice in the field, and then spreading that from the hub centers into the spoke centers. But it's a great question, and I think as the field continues to grow, part of the challenge is demand planning and getting sites up to a point where you're looking into the future. So we've had conversations with smaller community centers that have asked the question, do you need to have a washroom? Do you need to have lead line therapy rooms? And the answer to that question is that you need to speak to the CNSC and do that assessment to determine what you need. But the answer, if I'm just out of the gates going to give that answer, is no, you don't need to if the volume is low enough. But that's the challenge, is I think to your point, is that these volumes are going to increase. So if we're going to have a standard level of quality, we all need to have a really good sense of what the demand is coming in the future so we can plan appropriately.
So we'd like to thank our speakers for the lovely talk, and we'll move forward.